Illuminating pointers on the pivotal role of imaging in renal cell carcinoma. Now, let's move on to our next session on the gastrointestinal tract. We have another fantastic lineup of experts. Please join me in giving a warm welcome to the chairpersons for this session. Dr. Neha Bagri, Professor, VMMC and Safdarjung Hospital, New Delhi. Dr. Kartika Selvi, Senior Consultant Radiologist, Cancer Institute, Adayar. And Dr. Satish Kumar, Senior Consultant Surgeon, KMCH. To the chairperson's note, the queries will be raised by the delegates will be displayed on the laptop, which will be addressed during the discussion. First up, to take us through gastric malignancies, imaging basics, pearls and pitfalls, is Dr. Gaurav Raj, Professor and Head Radiodiagnosis, RML Institute of Medical Sciences, Lucknow. Now I request you to please take the stage, sir.
Thank you. Yeah, thank you so much. Very good morning. And let's start off with the GI session. So when you, what is the role of a radiologist for a gastric malignancy? One of the two. First is whether a thickening or a soft tissue nodule is a gastric malignancy. And second, if you have an established gastric malignancy, you have to stage it, you have to characterize it. So what imaging technique is the best? So for early stage carcinomas, endoscopic ultrasound is considered the best, the most sensitive and the most specific diagnostic test coupled with a biopsy. However, for staging, for overall staging, of course, CT scan is the best modality. Remember, PET scan does not have a very significant role because there are subtypes of carcinomas like mucinous and serous type which may not show hotspot on PET, and also sometimes the gastric mucosa will take physiological uptake. MRI per se does not have a role. There are papers which say that advanced stages of carcinoma may be better seen on MRI, but still they are under clinical trials. Now, how do you do a CT scan? We do a CT scan for gastric malignancy like we do all other CT scans. We do a triphasic with an arterial, portovenous and a delayed. What is the distension? You adequately distend the stomach with about 800 to 1 liter of water. You do not need a positive oral contrast until unless there is a fistula. Now, how much distension and how much is actually a thickening malignant? So remember, the stomach is like a balloon and it depends on how, expansile or distended your balloon is. So if it's not distended, you'll be able to see the rugal folds. If it's nicely distended, you'll just see a thin wall. So it's more of an eyeballing technique rather than a specific measurement that what is the thickness, is it abnormal or normal? That is a 1 layer, a 2 layered and a 3 layered thickness as it would seem on a CT scan. Now, there are a number of differential diagnoses. Now, your first job is sometimes instead of the patient going directly for an endoscopy and a biopsy, the physician or the surgeon may send to you that, okay, this thickening, is it malignant or not? Right. So what is the first differential? The first differential is a gastric lymphoma. Now remember the literature, and as you, most residents think that gastric lymphoma will usually present as a large thickening without gastric outlet obstruction, aneurysmal dilatation. Yes, that is one of the spectrum of gastric lymphoma, but remember gastric lymphomas can present like polypoidal growths, ulcerative, or even linitis plastica like growth, which are very similar to gastric carcinoma, but they are easy to differentiate from gastric carcinomas because you know that these are accompanied by lymphadenopathy, and mostly lymphomas are secondary in nature. So if you see a lot of lymph nodes, you see secondary involvement, hepatosplenomegaly, involvement of other GI and renal involvement, you are looking at gastric lymphoma. The second is GIST. GIST can be endophytic or exophytic and at times can be difficult to differentiate from adenocarcinomas, but GIST will usually not show any lymphadenopathy, will not lead to any gastric outlet obstruction. And remember, for GIST you do not use the RECIST criteria, you use the choice criteria. Then you can have rare mimics like that of sarcomas, which are very malignant and have a high rate of recurrence. Then occasionally you can have metastasis, like in this case, where you can see metastasis from CA ovary to stomach. Now, what do you think this case is? This is not gastric malignancy. Why is this not gastric malignancy? Look at the thickening, how hypodense it is. Remember, if a thickening is very, very hypodense, most probably that is due to edema, that is due to water. So this was a case of ulceration, right? What do you think this is? Again, gross thickening but very, very hypodense because of mucosal edema. If you can see here, that is the chronic calcification of the pancreas. So that is acute on chronic pancreatitis with gastritis. What is this? This is necrotizing pancreatitis with a large Waldorf collection giving rise to, again, reactive gastritis. So these are all thickening, but none of these are gastric malignancy. Look at the hypodensity, right? Then you can have, rare disease like protein losing Meniere's disease. Okay, this one. I've got 3 cases. What do you think is the first, the second, and the third? The first one, uniform thickening, hypodense, most probably peptic ulcer. This one, again, uniform thickening, showing some enhancement, not as hyperdense. The third one showing good enhancement. So, the first one is inflammation from peptic ulcer. The second one is lymphoma, showing some contrast enhancement, and adenocarcinomas usually enhance very well. So remember, whenever, and of course you can have things like carcinoid and polyposis also in the differential. So remember, whenever you have linitis plastica, remember that all linitis plastica will not be circumferential thickening of the whole stomach. They usually start off with little bits of pieces of thickening which slowly, progress to full thickening. Always, whenever you have a thickening in the stomach, whether benign or malignant, do look at the gastrohepatic ligament, because gastric malignancies are notorious for very early lymph nodes. So look at this site, and most probably if this site is clear, there are no lymph nodes, it is not a malignancy. If there are lymph nodes, it is a malignancy. What do you say? This is gastritis, lymphoma, or linitis? Thickening, right? You can see some thickening. So if you look carefully, you will see the thickening. What is this thickening? This is the thickening of the gastrohepatic ligament, right? So gastric hepatic ligament thickening along with ascites, you are very sure this is nothing but gastric malignancy along with peritoneal metastasis. Now, once your, the diagnosis is established that you have a gastric carcinoma in hand, the second thing is to stage it. Now, the staging of gastric carcinoma is based on the depth of infiltration of the tumor into the wall of the stomach, right? Now, how do we stage it? Like any other TNM staging, we first do the T staging, which depends on the primary tumor's morphology, location, and extent. Then we go for lymph nodes, and then finally for metastasis. Right. So what can be the appearance of gastric carcinoma? Remember, all gastric carcinomas will not look like linitis. They can just be seemingly as a small enhancing nodules, anything more than 1.5 times normal wall thickening, or they can be superficial, very superficial, early stage. They can be polypoidal. They can be constricting, leading to gastric outlet obstruction. They can be mass forming, leading to gastric outlet obstruction, or they can be diffuse and linitis type of morphology. Now, what about enhancement? Yes, most adenocarcinomas would enhance well on CT scan. However, remember, mucinous and serous types of adenocarcinomas at time will not show enhancement. So this is a example of a typical adenocarcinoma showing good enhancement. This is an example of an mucinous type of mucinous type of gastric carcinoma not showing any enhancement. So enhancement per se is difficult to differentiate the subtypes of carcinoma. Size and measurement. So Rices says that you cannot actually measure a gastric carcinoma perfectly because of the distendability issues of the stomach. However, you need to give a larger diameter, 2 diameters AP, and transverse diameter for follow-ups. Remember, once again, for early staging of cancers for T1 and T2, CT is not a very good modality. However, for T3 and T4, advanced stage CT is an excellent modality. Yeah, so this is the T staging. So basically we start with T1, which is the infiltration of just the submucosa, and the mucosa very difficult to identify on CT. Then there is T2, which is involvement of the muscularis propria. T3, which the tumor just extends to the subserosa. The T4A, which is involvement of the serosa, and T4B when you involve the adjacent structures. Right, so that's a T1 where you can just see some subtle enhancement of the mucosa. A T2 where you can see full thickness enhancement of a part of the stomach but no infiltration of the outside fat. T3 where you can see some nodularity with maybe some perigastric stranding. T4A, you can see this nice enhancement of the outer layer, which is the serosa. When the serosa is involved, it becomes a T4 state. So this is the serosal sign in T4A, and this is the T4B, where the cancer has, infiltrated the adjacent structures. Now, case examples, that's a T3 gastric carcinoma, where you can see a nodular carcinoma infiltrating, and you can see a lot of perigastric lymph nodes just adjacent to it, but the carcinoma is not infiltrating into the adjacent structures. That's a T4A, where you can see the tumor is going just outside the stomach with large lymph nodes and some perigastric infiltration. That's a T4B, where the stomach is showing fistulization into the adjacent colon, infiltrating into all the adjacent visceral structures. Now, the second, the most important, is lymphatic dissemination. So, unlike other cancers, in this case, lymph nodes are so very important, because at least in our setup, at least 80% of the cases when they come to you would have metastasized to lymph nodes. And now we know that size is no more a criteria. We know that even lymph nodes as small as 5 mm may harbor metastasis. So it is always morphology which we depend upon. The shape and size of the lymph nodes, whether they are heterogeneous, whether they are circular, whether they have irregular margins. Now, there are three main categories in which these lymph nodes are divided: the perigastric and the extraperigastric and the metastatic ones. So that is the lymph node classification. The numbers are important. So N1 is 1 to 2, N2 is 3 to 6 regional, N3 is 7 or more. So actually the classification of lymph node, that's a busy slide. That's the Japanese classification for lymph nodes. It's a difficult one. So what we do is that we stick it in our reporting room and the residents use this. But it's very important to, write down all the gastric nodes in the station, because the surgery plan actually depends totally upon the lymph node. So depending upon the stations of lymph node involved, the surgeon is going to do that type of gastrectomy along with that type of lymphadenectomy. Right. So some examples of lymph nodes. So that's a small lymph node just posterior to the pancreatic head. Remember, if you do not remember the stations, it's perfectly okay. What you need to do is just write down the region. You see a lymph node, write down it is posterior to the pancreatic head. It's at the splenic axis, and the surgeon itself will sort of sort it out. So that's a lymph node posterior to the pancreatic head, and according to the Japanese classification, that would be considered a compartment 3, but according to the American, it would be a M1 or metastatic disease. That's another. So as I said, always follow the vessels. So that's your common hepatic artery, and then if you trace it, you see a small lymph node just along it. Now look, this lymph node does not look suspicious. It is oval in nature. However, I would recommend that in gastric carcinoma reporting, please report whatever lymph nodes you are able to see, because most probably what lymph nodes you are seeing in perigastric area and along the celiac axis would be malignant. That is along the celiac trunk. So you trace the vessel, and then along the vessel you see a small lymph node. That would be your station 9 lymph node. Right, so that's along the splenic artery. You see a lymph node, a juicy lymph node. So that would be a station 10, and when a station 10 lymph node is involved, they usually do a splenectomy along with a gastrectomy, because they consider it to be metastatic. Now, very important, the routes of spread. What is the route of spread? How a gastric carcinoma spread, right? So the importance is to differentiate between subperitoneal and transperitoneal spread. The subperitoneal is T3 and the transperitoneal is T4. So what happens is that the stomach is surrounded by ligaments. So the serosa of the stomach is nothing but the visceral peritoneum. And so if you have the tumor going into the visceral peritoneum along the ligaments, it is known as the subperitoneal spread, or the T3 of the gastric carcinoma. However, if you have the malignancy just infiltrating and going directly out of the peritoneum, that is known as transperitoneal spread, and that would be a T4A stage. Now, all these perigastric ligaments, hepatoduodenal, perigastric ligaments, are all routes for subperitoneal spread and T3 disease. So that's an example. You've got a small carcinoma, and you can see this carcinoma from the gastric is going into the liver. So that would be through the gastrohepatic ligament, perigastric ligament, and that would be a subperitoneal spread. This is, you can see the tumor is going directly into the colon through the gastrocolic ligament. So again, a subperitoneal spread. Now, transperitoneal dissemination, though CT is a good modality, remember that these very small transperitoneal spread or peritoneal metastasis can be missed on CT, and laparoscopy is superior to any other imaging modality with a very high sensitivity, and they say that always diagnostic laparoscopy must be done before invasive surgery. So, how can transperitoneal dissemination be seen on CT scan? The most common is, of course, ascites. If you have ascites, you know that the disease has gone into and spread all over the peritoneum. The second is, of course, you can have definite soft tissue nodules in the peritoneum, or you can have this kind of layering over the mucosa of the large or the small bowel ring, which are plaques of metastasis, or you can have irregular omental thickening, irregular peritoneal thickening, what we call typically as peritoneal carcinomatosis. Right. Of course, then you can have your classic Krukenberg tumor, right, which usually happens in the signet red histology. Remember that they can also happen in colon, breast, and lung apart from stomach. Now, then you have your T4B, where you can have the tumor directly invading into adjacent structures. So that's a carcinoma which is going directly fistulizing into the colon. Now, these kinds of cases, if you have an idea that there is a fistula, it's a good idea to use a positive oral contrast, something like gastrographin or contrast mixed oral, right? That is a carcinoma of the stomach infiltrating directly into the pancreatic tail and spleen. That makes the disease surgically unamenable, and a chemoradiotherapy has to be done. Now, remember, of course, that if vessels are included, especially the root of mesentery encasement and all major branches encasement of aorta, you cannot do a surgery other than splenic artery, because if a splenic artery is involved also, they'll do a splenectomy and a full surgery can be done. Now, remember that T4B is invasion or extension into the adjacent structure. So, if you have a carcinoma stomach which extends into the esophagus or extends into the duodenum, it is not T4B because it is direct extension. So, it is not adjacent, it is not T4B. Now, coming to the last part of the presentation, hematogenous dissemination. So, the common organs involved in hematogenous dissemination are liver, lung, bones, adrenal. Now, since the stomach is drained by the portal system, so the metastases are mainly hypovascular, and they are best seen in the portovenous phase. Also remember that station 13 to 20 nodes are considered to be through hematogenous spread, and also supraclavicular virtue nodes. Now, bone metastasis, like any other malignancy, the bone metastasis can be there. Now, one interesting fact about gastric carcinomas, like few other carcinomas, is that apart from the mets being sclerotic or lytic, they can also be isodense. Now, when a mets is isodense, it becomes very difficult. What do? Then the role of PET comes. So here you can see there is a metastasis. You can see nothing here. On a PET, you can see a hot spot. Right, so this came out to be a metastasis, right? So iso-intense or iso-dense metastasis can be seen in stomach. Now, one more important aspect is, suppose you have a spine like this of gastric carcinoma, you see no metastasis, and the treatment you have started with a chemoradiotherapy, and then after some time you see lesions like this. What are these? These are newer lesions of sclerotic type. Yes and no. Yes, maybe they are new metastases, but most probably they are not new metastases. What this is that these are treated metastases. So a lot of isodense metastases on being treated will become hyperdense or sclerotic. So maybe whenever you see new hyperdense sclerotic mets, just give it a thought. Was it that earlier they were isodense, I could not see it, and now after chemoradiotherapy they have become hyperdense. Right, now coming to the conclusion. So your role first is, of course, to identify, as I told you, to differentiate the malignant masses from the inflammatory. Once you have done that, once you are confident that you have a malignant mass in hand, then you characterize the tumor. What is the morphology, whether it's polypoidal, ulcerated, diffuse, what is the contrast enhancement, what is the location. Then you do the staging. Remember, it's perfectly okay if you're not very accurately able to stages at T1, T2, T3, T4, but at least you should be able to tell the surgeon. You should be able to tell the surgeon whether it is locally advanced or early stage. That is, whether it is T1, T2 or it is T4A, T4B. So even if you say that, your job is done. Second, very, very important, lymph nodes. You cannot miss lymph nodes. You have to label all the lymph nodes according to the station. If you cannot do that, at least whatever lymph nodes you can see, please tabulate them and let your physician and surgeon know about them. Then metastasis, we talked about all kinds of metastasis. Remember that liver is the most common site of metastasis with hypovascular mets seen best on portovenous phase. And do not remember that sclerotic mets after treatment can happen. Thank you.
Thank you, sir, for the excellent talk and giving us a glimpse into your invaluable methods of approaching gastric malignancies. It will be of immense use to us all. Now, let's move on to the imaging the spectrum of small bowel tumors presented by Dr. Madhusudan, Professor Radiology, AIIMS, New Delhi. We welcome you on stage, sir.
Hi, thank you, everyone. So let me. So small bowel tumors, it's a wide topic. So let me try and finish off in the next 20 minutes. So these small bowel tumors are rare compared to the length of the small bowel, and so they constitute about 3% of the GI tumors. And the overall frequency of the tumors decreases from proximal to the distal end, that is from duodenum to ileum. And then 50% of them are asymptomatic. So many of them are incidentally detected because of the non-specific symptoms which the patients present with. So clinical presentation, as I said, most often they are vague. So presentation as in the form of lump or some GI symptoms like some obstruction, recurrent obstruction, or GI bleeds or anemia. So these can help a clinician to suspect a small bowel origin. Otherwise, when the symptoms are vague, then it's very difficult to say that the patient has a small bowel tumor. And then sometimes they may present with complications because of the mass effect like jaundice, obstruction, bleeding, or perforation. So we have tried to summarize into benign and malignant tumors. So these are the list of common benign tumors which are seen with respect to small bowel. So adenomas typically arise from the glandular epithelium. The morphological types depends on the morphology, that is the appearance of the polyp. They can be either tubular polyp or tubulovillous or villous. So from the tubular to the villous end, so initially the tubular ones are more benign and then the villous ones are more malignant. So so management wise this becomes important because the tubular ones, if they are smaller and do not have any kind of dysplasia on biopsy, they can be followed up. Right, and then most of the villous adenomas, because they have high chances of malignancy, they are usually resected. And then these may be associated with polyposis syndromes as well. So ampulla is a common site for adenomas. So this is one case where you can see there is a small polypoidal lesion right at the level of the ampulla on the corneal and the axial images. So this is the lesion there, and then this is causing obstruction and the patient presented with jaundice. Because of the location of the adenoma, the patient presents early with the symptoms. So this is an MR of a different patient where you can see a small polypoidal lesion right at the level of the ampulla, and so these were papillary adenomas or polyps at the level of ampulla. Sometimes there may be multiple, as I said, with polyposis syndrome. So these are the typical hematomatous polyps which are seen in patients with Peutz-Jeghers syndrome. And then because they mainly project into the lumen, they can cause obstruction because of intussusception. As in this case, you can see the typical target appearance due to the presence of intussusception caused by the polypoidal lesion. So the other common benign tumor of a small bowel is lipoma. So it's easy to identify. Very often they are incidentally detected on a routine CT scan which is performed. So typically has this fat density, as you can see here. So it has a very typical fat density within the lumen projecting. So often they are incidental, but sometimes if they are large, if they cause mucosal ulceration, the patient may present with recurrent GI bleed or anemia. So in that cases they need to be operated and taken out. Otherwise they don't have any so they don't have any malignant potential and they can be left alone. So the uncommon benign tumor is leiomyoma. Again, so this is something which we cannot diagnose on imaging because the morphology is more or less similar to other benign tumor like an adenoma or a polyp. So as you can see here, so this was a case of intussusception. Patient presented with abdominal pain. So there was a lead point right at the level of distal ileum. So this is the ileum, and then with ileocolic intussusception, there was a lead point. And so we had suggested an adenoma or a polyp. So this turned out to be leiomyoma at surgery. So again, as I said, so the appearance is very homogeneous, like a polyp, like an adenoma, so it's very difficult to make a preoperative diagnosis of a leiomyoma. But again, just to complete the list of benign tumors, so this is one of the cases of leiomyoma of a small bowel. These are the list of malignant tumors. So gastrointestinal stromal tumor, so this can range from benign to malignant, because unless otherwise classified, we consider all GIST to be malignant. And then, so they are classified based on the risk wise, which I'll be talking about later on. And so typically they arise from the interstitial cells of Cajal, and then the typical appearance is of an endophytic or an exophytic, predominantly exophytic mass lesion arising from one of the walls of the small bowel. So most common site is duodenum and jejunum. So this is one case of jejunal GIST, gastrointestinal stromal tumor. You can see, so this is the wall of the jejunum, and then you can see a small intraluminal lesion and a large exophytic component arising from the jejunal wall, and then there is ulceration as well with a small cavitation. So this is the typical appearance of a gastrointestinal stromal tumor. These are the corneal images, which again shows the small endophytic component and a large exophytic component with an ulceration and small cavitation. So this is an early stage of gastrointestinal stromal tumor. Sometimes you can see, often we see a large lump with large cavitating lesions like this, where you can see a large mass, large cavitating mass arising from one of the walls of the small bowel. And then as the size increases, the potential of them being malignant increases, and there are more chances of metastasis when the size increases. As you can see in this case, so the patient had multiple liver metastasis as well. So this was another case where you can see a large jejunal gastrointestinal stromal tumor with multiple metastasis, peritoneal metastasis. So the two common sites of metastasis in patients with gastrointestinal stromal tumor are liver and peritoneum. So it is typically said that the nodal metastasis is uncommon, so which helps in differentiating gastrointestinal stromal tumor from lymphoma. But again, up to 10% of them can have still regional nodes. So they may not have distant nodes, but regional nodes are still can be seen with gastrointestinal stromal tumors. So this is the risk stratification which I was talking about. So imaging plays a role in a few of the factors. One is to identify the tumor size. So the smaller lesions are of low risk type, whereas larger lesions more than 5 centimeter will have higher risk. And then the location of the tumors which are in the stomach have low risk, whereas compared to tumors in the small bowel which have a higher risk. And then presence of tumor rupture. So tumor rupture is also one of a factor which will indicate whether the tumor has higher risk or not. Then most important thing is that surgery, after surgery or after biopsy, depending upon the mitotic index, the pathologist gives a proper risk categorization of the GIST which has been operated. So there are a few syndromes as well which are associated with GIST. So a few of them include NF1. So this was a case of NF1 where you could see multiple tumors arising from the duodenum and jejunum. So these are all gastrointestinal stromal tumors. And then you have Carney's triad, where you can have, the patient can have multiple GISTs, pheochromocytomas and pulmonary chondromas. So in a patient who has these multiple tumors, you should think of a syndromic association, and then you need to work up the patient for the presence of them. So the other small bowel malignant tumor are adenocarcinomas. So they typically arise from the glandular epithelium. Most common site is duodenum. So they typically have this apple core kind of appearance, causing luminal narrowing and obstruction. As in this case, you can see this is a case of jejunal adenocarcinoma. You can see the circumferential asymmetric kind of wall thickening, and you can see that these are the corneal images causing luminal narrowing and dilatation of the proximal bowel loop. So this is the typical appearance of an adenocarcinoma. You have an apple core lesion causing obstruction and dilatation proximal to it. This is another case of duodenal adenocarcinoma. You can see a circumferential wall asymmetric wall thickening in the third part of the duodenum causing proximal dilatation. So this is the typical appearance of an adenocarcinoma. So the next is a neuroendocrine tumor. So they have a different kind of appearance. They are very vascular tumors, and they are most common in the distal ileum. So they may be uncommonly, they may present with carcinoid syndrome and carcinoid crisis, but often this is not the case because most of the patients can be diagnosed before they present with carcinoid syndrome itself. So these are the imaging appearances of neuroendocrine tumors. You can see, so they're very vascular tumors. This is the case of duodenal neuroendocrine tumor, small polypoidal lesion arising from the wall of the duodenum. And these are the arterial and the venous phases where you can see the lesion showing persistent enhancement. But the arterial phase is the one which will give you a clue that it is a vascular tumor and more likely to be a neuroendocrine tumor because of the intense enhancement. So this is a polypoidal variety. Sometimes you can have plaque-like wall thickening as well, again showing enhancement in the arterial phase. So these suggest that they are vascular tumors, again stressing that they are likely to be neuroendocrine tumors. So they can have a big, the primary lesion may be small, but they can have huge nodes as well. And then you can see multiple metastases within the liver, again being very hypervascular. As in this case, you can see the small jejunal tumor, but the nodes are very huge. The liver metastases are very huge. So you can have typically the neuroendocrine tumors as shown in this case are the primary ones is very small, whereas the nodes and metastases will be very big in size. So again, more examples. This is a small plaque-like thickening in the ileum, distal ileum, and then the other thing is the presence of mesenteric nodes. So because of the serotonin and 5-HU which they secrete, there is a lot of desmoplastic reaction which happen around the nodes in the metastatic nodes. So this is the primary lesion in the ileum, and then there is this desmoplastic reaction and large nodes which can cause this speculated appearance around the mesentery, which again gives a clue that this is a neuroendocrine tumor. So this is the MR of a different patient where you can see a small primary tumor in the ileum, and then there is this extensive desmoplastic reaction all around the nodes in the adjacent mesentery. So sometimes what happens is these desmoplastic reaction can involve the vessels, and then they may cause constriction, obstruction of the veins as well as the artery, and then they cause ischemic changes in the surrounding bowel. So there's also a complication which can happen with the desmoplastic reaction occurring because of neuroendocrine tumor. Next is lymphoma. So they can be primary or secondary. And then, so GIT is the most common site of extranodal lymphoma, and again ileum is the most common type because there is a lot of lymphoid tissue in the ileum. So there is a criteria which has been defined to say whether the lymphoma arising from the bowel is either primary or secondary. So absence of any systemic disease, and then absence of any involvement of the bone marrow, liver or spleen, and then so presence of only regional lymph nodes and no distant lymph node. These are the criteria which have been defined to say that the lymphoma which is seen in the bowel is primary small bowel lymphoma and not a secondary one. There are various imaging morphologies which have been described in case of small bowel lymphoma. The common ones are the pseudoaneurysmal ones. So you can see here. So there is this nodular gross thickening of the small bowel of the distal jejunum proximal ileum maybe, and then you can see that despite the presence of these extensive wall thickening, the lumen is still seen, and in fact it is dilated as well. So this is the typical aneurysmal variety of lymphoma, where it typically involves the mesenteric and the submucosal Meissner's plexus, and then causes dilatation of the bowel at that segment. And then you can have multifocal involvement as well. You can see another segment of the bowel which again shows wall thickening with no narrowing of the lumen. The other variety is polypoidal variety. You can see a large polypoidal lesion projecting into the lumen of the ileum. So this is a polypoidal variety of lymphoma. Then other morphologies include the exoenteric or the cavitary form. So this is a large cavitary mass arising from the small bowel. So this typically mimics GIST. So you can have this kind of large mass with large cavitation which is communicating with the lumen and showing air foci within them. And then you have stenotic form. This is an uncommon form which is seen. So typically, as I said, they involve the plexus and cause luminal dilatation, but occasionally they can cause stricture as well. As in this case, you can see a gross wall thickening in the region of jejunum and then causing proximal dilatation. So this is an uncommon form, but you need to know that this can happen. And then you have the typical mesenteric form, which is again commonly seen, where you can see wall thickening of the bowel and then there is direct extension of the mass into the mesentery. So you can have the mesenteric form as well. Then lastly, metastasis. You can see metastasis to the small bowel are uncommon. This typically happens when any primary malignancy has disseminated metastasis. So it can be either hematogenous or contiguous involvement or a peritoneal spread into the small bowel. So these are some examples. This is a case of melanoma, ocular melanoma, and then the patient had recurrent abdominal pain, and then when a CT was done, it showed a small intussusception with an enhancing lead point. So this was a metastatic melanoma into the small bowel arising from a choroidal melanoma. And then this was a case of CA lung. You can see a large mass, and then there was disseminated metastasis everywhere, and then you can see multiple nodules in the proximal jejunum. So these are metastases in the bowel, small bowel. Sarcomas, again, these are uncommon. Again, diagnosing them on imaging is difficult. Most of them appear similar to a GIST. So we usually give a possibility of GIST, and then at only surgery we get to know that, or biopsy we get to know that this was not GIST and this was leiomyosarcoma. Otherwise, imaging wise, they are more or less similar to gastrointestinal stromal tumor, appearing large, heterogeneous. They may show cavitation as well, similar to a GIST. These are the list of complications which can happen, as in shown in few of the cases, depending upon the location. Typically in the region of ampulla, they can cause biliary obstruction and can cause jaundice. And then intussusception, many of the polypoidal lesions have a risk of intussusception. They can prolapse into the lumen and cause intussusception and cause obstruction. And then GI bleeding, vascular tumors like neuroendocrine tumors, gastrointestinal stromal tumors can bleed, and then so that the patient may present with emergency GI bleeding. And then, so as I said, mesenteric ischemia is a complication which can happen when the desmoplastic reaction involves the mesenteric veins and mesenteric arteries, causing bowel ischemia. Management, so surgery is the most important treatment for most of these lesions, depending upon the stage of the lesion. So as I said, small benign ones can be left alone, like lipomas or small polyps less than 1.5 2 centimeter, but otherwise most of the lesions are operated, and surgery is the first line of management. And then if the disease is unresectable, then chemoradiotherapy, whether it is neoadjuvant, like in case of GIST, if it's a large GIST, then TKIs can be given to reduce the size and then make it operable, or in neuroendocrine tumors, you can give SSTR inhibitors to reduce the size so that the surgeon is happy to operate these tumors. So before concluding, I've just, so this was a complete list of tumors which can be seen with small bowel. So when you approach a small bowel tumor, it all depends whether you are clinically suspecting a small bowel tumor or not. So if the patient presents with symptoms related to a small bowel like maligna, anemia, obstruction, or a lump, then a CT enterography, typically a dual phase CT enterography should be done, which will help you in identify and stage the tumor. And then if it is unsuspected, then it's usually a routine CCT abdomen, which you do with either a positive contrast or a neutral contrast. The role of MR is not very much in routine tumor evaluation, but in patients with polyposis syndrome, to reduce the exposure to radiation, you can get MR enterography done repeatedly during follow-up. So based on morphology, as I said, if it is endophytic, then you can have polyps and adenomas, and small GISTs can be endophytic. So that's the possibilities which you can give. If it is intramural, any of these lesions like GIST, NET, adenocarcinomas, and lymphoma are intramural in appearance. And then exophytic, typically GIST and lymphomas are the ones which have the characteristic exophytic appearances. The enhancement pattern, if it is hypervascular in arterial phase, then neuroendocrine tumors and GIST are the differentials, and most of the tumors are hypervascular, and so you have a big list of them. So if there is necrosis and cavitation, as I said, GIST and lymphoma are the possibilities, and if it is fat density, then it's lipoma, it's easy to diagnose. The numbers, most of the tumors are solitary, but if you see multiple tumors, then you should think of either polyposis syndromes or GIST-related syndromes like NF1 or Carney's triad. And then lymphomas and metastasis can also be multiple. Locoregional nodes, again, if the nodes are hypervascular, so typically it is neuroendocrine tumor, and if they are large and bulky, then you should think of lymphoma. Then there are few associated features. If there is aneurysmal dilatation, so it is typically seen in lymphoma, not necessary, but typically it is seen in lymphoma. And then if there is a mesenteric mass with spiculated margins, then neuroendocrine tumor is a possibility. And then if there is already a history of a syndrome like a neurofibromatosis or some other kind of syndrome, then you should think of that diagnosis related, the tumor related to that particular syndrome. And if there is primary malignancy elsewhere, then there is a differential of metastasis coming from that primary malignancy. So lastly, just to before concluding, I'd like to show you this case. So this is a case of large mass arising from the duodenum. You can see a large nodular kind of mass from the second and third parts of the duodenum. So any suggestions? What could this be based on, what you have seen? So, so because the thickening was gross and then there was no luminal narrowing, we had given a possibility of lymphoma. But again, so when the biopsy was done, this was turned out to be adenocarcinoma. So again, as I said, imaging is very helpful and it can give suggestions in characterization, but it's not foolproof. And what the surgeon needs is the staging of the tumor rather than a proper histology of the tumor. So we need to tell the surgeon whether the lesion can be operated or not. So that's the most important thing. So in conclusion, the small bowel neoplasms are uncommon and CT enterography, whenever possible, has to be done so that you can define the tumor very well, you can stage the tumor very well, and so the surgeon is happy with the information you give him. And then, so high index of suspicion, as I said, is very important for optimal imaging. Thank you for your kind attention.
Thank you, sir, for the comprehensive discussion and emphasizing on the crucial and often underappreciated role of a radiologist in the management of small bowel tumors. Moving on, let's welcome Dr. Anuradha Chandramohan, Professor and Lead of Abdominal Imaging, CMC Vellore, on the stage for a talk on a comprehensive overview of imaging in colorectal cancer.
Very good morning, everybody. Very good morning, everybody. At the outset, I want to thank the organizers for having me over and for the excellent organization. And let's just dive into this topic. What I'm going to do in this very broad topic is take you through 4 different clinical scenarios and emphasize on the role of imaging in the management of colorectal cancer patients. So let's dive into case number 1. This is about a 54-year-old male patient who had presented with fatigue for 3 months, altered bowel habits for 6 months, and had a hemoglobin of 7 gram%. The clinical examination was unremarkable. There was only pallor. An upper and lower GI endoscopy was requested but not yet done, and stool occult blood was given and the results are awaited, and the patient is referred for imaging. So this is a typical clinical scenario that we see in our practice. So how do we go about this, and what should be the focus of our imaging review in this scenario? Our imaging review would be focusing on identifying the cause of occult GI bleed because there is a hemoglobin drop, and there's a hemoglobin of only 7 gram%. You also want to keep in mind the conditions that would impair or infiltrate the bone marrow, like leukemia, lymphoma, and certain types of malignancies like pancreatic cancer and ovarian cancer, which can impair marrow. And most importantly, occult GI bleed, if you look at the differential, top of that list is right colon cancer, gastric cancer, diverticulosis, hiatus hernia, and other things. So if you did find a mass, the questions that will be in front of us would be how to obtain a histopathological diagnosis, how can we stage the cancer, and who are the stakeholders for the management of this patient. So this is what we need to address. So what is the most appropriate imaging? It would be the CT thorax, abdomen, pelvis, or you can choose CT enterography with a neutral oral contrast, or you can do a CT colonogram either with a neutral or a negative oral contrast. But PET CT oftentimes won't be the first choice because it's one, expensive. Secondly, many malignancies or many conditions might not be FDG avid. Apart from that, to identify the source of occult GI bleed, it would be very difficult with the kind of resolution that your PET CT would offer. So it would not be the most popular first choice. So this patient underwent CT abdomen and pelvis, and I'll scroll the let me scroll the venous phase of this patient, and what we see is a normal liver and spleen. And as I go down and focus on the large bowel, you can see a circumferential enhancing wall thickening in the right colon, and There is also thickening of the adjacent peritoneum, some fluid and fat stranding, multiple lymph nodes in the pericolic region, and the arrow points to one of them, and ileocecal junction was normal. There was some fat stranding in the right iliac fossa, which the arrows just showed, and the rest of the abdomen was normal. There was no bowel obstruction. So what did we interpret this as? We called it a non-obstructing annular right colon cancer with an extramural spread of more than 5 millimeters, thickened adjacent peritoneal lining, more than 4 pericolic lymph nodes, and there was no metastasis on this chest CT of this patient, which I have not shown you. So we staged it as a CT T4A N2 N0 stage right colon cancer. So this patient underwent right hemicolectomy, and the surgery did confirm that it was a right colon cancer, but there was no peritoneal metastasis, and the margins were negative at surgery, and lymph nodes, up to 22 lymph nodes were harvested in this patient. Out of the 22 nodes harvested, only one was positive. So N1 stage is less than 4 lymph node, N2 is more than 4 lymph node, and within N1 also, if you have 2 or less lymph nodes, it's N1A. So that is the final pathological stage. Only 1 out of 22 harvested nodes was positive, and it was finally staged as a pathological T3 N1A stage 3B colon cancer on pathology. So patient came back for an MDT discussion again for further management. And how did we manage this patient who was diagnosed with a stage 3 low risk colon cancer? We went and did an MSI. MSI is microsatellite instability. When we tested for it, it was high. So how does that matter? It matters because the MSI high patients respond extremely well to immunotherapy. So the options and the MDT suggestion for this patient is that adjuvant systemic chemotherapy should include an immunotherapy. And so the options that were given to the patients is one of those two options, K-pox, Folfox with an immunotherapy and without an immunotherapy for a larger number of cycles. So the take-home points from this scenario is that right colon cancer is present with anemia, and the imaging tends to overstage, and we must be cognizant of that, especially in the era of Foxtrot trial. After the Foxtrot trial, neoadjuvant chemotherapy for colon cancers is becoming popular, and so we must be aware as a radiology community that we are prone for overstaging. And accuracy of CT for T staging is 60 to 80%, and N staging is really abysmal. It's only 30 to 56%. But our role is to aid in diagnosis and prepare the MDT to take the right steps. And always in a right colon cancer, advise MSI testing, as I showed you in this example. Let's show you this companion case of a patient, 63-year-old female patient who presented with an acute abdomen, and she had pain and guarding. And she had altered bowel habits for 6 months. She had alternating episodes of diarrhea and constipation. She had obstipation for 2 weeks. And we did an emergency CT, abdomen and pelvis. And I'm going to scroll the venous phase images of this patient. And as I scroll, you can see that the liver is normal. There are no focal lesions. Spleen was normal. As I scroll down, you can see a borderline sized round iotocaval lymph node. As I go down further, there are a few dilated small bowel loop measuring up to 3.6 centimeter. There's a lot of fat stranding, and I'm showing you a collection with air pocket. As we go down further, there's a lot of fat stranding, and there's enlarged left ovary, a bulky right ovary for a 63-year-old. And there is a circumferential nodular thickening of the sigmoid colon with a lot of extramural spread along the anterior wall with a lot of fat stranding, minimal fluid in this patient. So what did we conclude in this case? We called it annular growth in the sigmoid colon, collections in the pelvis, peritonitis, bulky ovaries for a 63-year-old, borderline sized iotocaval lymph node, and staged it as T4A N1C M1C because there were a lot of lymph nodes, bulky ovaries, which made us lean more towards probable peritoneal spread despite peritonitis, which can be very difficult in our practice, and said HRCT should be done to complete staging, and which was subsequently done, and there were no lung metastases in this patient. Because it was an acute presentation despite a higher stage disease, this patient had to be operated and underwent a sigmoid colectomy, and intraoperatively there was a perforated sigmoid colon cancer, ovarian metastasis, and peritoneal spread, and patient underwent sigmoid colectomy, drainage of the collection, transverse colostomy, and the pathological stage concurred with the imaging stage we gave, and the patient then went for chemotherapy with a palliative intent. So what did we take home from this case? Left colon cancers obstruct and may perforate. Imaging must address the staging requirement. So HRCT must be done to complete staging before you start chemotherapy. And perforation can lead to overstaging. And despite advanced stage in these kind of patients, surgery will be unavoidable because without taking care of sepsis, you can't give chemotherapy. So we have to drain or address the most critical problem first. So we'll take a small break, and I want you to pick up your phone and click on this QR code to access the structured reporting template for colon cancer, which is by the National Cancer Grid. And you can also access a list of structured reporting template for most common cancers in India in the NCG website. So let's move on to scenario number 3 of okay. So I'll give you a moment more. Okay. So the scenario number 3 is about an 89-year-old female patient, an elderly female patient who presented with an increased stool frequency after spicy food for 3 months. And she had occasional melena for 3 months, right-sided abdominal pain for 3 days, and her hemoglobin was low, 7.8, and she had a microcytic hyperchromic anemia. Her emergency CT abdomen pelvis showed a long segment, mild diffuse bowel wall thickening, and was reported as colitis and nothing else. Subsequently, the next day, patient underwent tumor markers, colonoscopy, upper GI endoscopy, and the CEA level was elevated 15.3, and upper GI endoscopy was unremarkable except for some inflammatory changes, but colonoscopy revealed a polypoidal growth in the descending colon, and the biopsy subsequently revealed a tubulovillous adenoma, high-grade dysplasia, and foci of invasive cancer. Other significant history in this patient were multiple comorbidities, and she also had a hysterectomy for endometrial cancer 22 years ago, and she had a strong family history of cancer. 4 out of 6 siblings had cancer, esophageal cancer in 2, breast cancer in 1, Hodgkin's lymphoma, non-Hodgkin's lymphoma in 1 sibling. And then the patient's images were reviewed at the MDT, and we saw the patient had this abnormal thickening in the descending colon, and that's the thickening, not much extramural spread, and we reported at least 1 node which is not shown here, and we called it an early T3, early because the extramural spread was less than 5 millimeter, early T3 N1 descending colon cancer at the MDT, and there was only a hemangioma in the liver and nothing else. And we advised chest imaging to complete staging, and the chest imaging subsequently was done with the clinical data and reported no lung metastasis. At the MDT2, we reviewed the HRCT and we said T3N1 M0 clinically, so go ahead with colectomy, and then she underwent colectomy, which was a pathological T3N2 and N2 colon cancer. And again, notice out of 15 nodes harvested, 13 were positive, and we only found 1 lymph node. So this is common in clinical practice, but don't worry about it because these nodes would come out in your surgical specimen. So we don't have to beat ourselves about that. The first surveillance imaging done at 3 months, this patient being elderly had to have a Hartmann's, and so she had a stoma, and hemangioma was stable, and The HRCT done as a part of the review, the CT thorax, abdomen, pelvis shows a large left breast mass, and there was skin thickening too, and it was a 4 centimeter mass, ER positive breast cancer in the left. Hindsight is always good for radiologists, and we went back to the imaging, and you see a speculated mass in the left breast, which was completely missed initially. So lesson number 1, your checklist must also include reviewing areas associated for cancers associated with genetic mutation, especially in colon cancer patients, women operated previously with endometrial cancer, breast cancer, etc. And so you must include these in your review areas. And she perfectly fitted the Amsterdam 2 criteria for Lynch HNPCC, where she had more than 2 first-degree relatives with different cancers. And this is the table showing you the lifetime risk of different cancers in Lynch, and topping that list is breast and endometrium and colorectal cancer. BRCA can also be associated with colon cancer, so that is also something to be checking out for. And our patient was tested for BRCA and she was negative. And finally, she was concluded to have Lynch and had her whole family screened for Lynch subsequently. So reflection 2 of this case is the way we review cases as an experienced radiologist versus a resident. Their perceptual expertise is very high among experienced radiologists. So we have very refined search patterns which are very tuned to checklists that we've already developed in our head through our experience based on the clinical data and information given to us. But always it would help to retain a little bit of beginner's discipline when it comes to different real life clinical situations. So another example a few years later, that's a mid-rectal cancer, intermediate signal intensity, the posterior wall, and T2N0 rectal cancer with a very good distance to mesorectal fascia, totally amenable to upfront surgery, but the HRCT of this patient revealed an unresectable pancreatic cancer in the tail region, which was completely encasing the splenic vessels. And so that's a pancreatic cancer, and similarly a mutation associated with colorectal malignancy. Let's move on to finally the case study 4, which is about a 54-year-old female patient who had constipation, perineal pain for 1 year. Sigmoidoscopy revealed a low rectal cancer, which was poorly differentiated on biopsy. She was MSI stable, and imaging that was done in her was MRI pelvis for local staging, and she already came to our center with a whole body PET-CT images available. And so this was a low rectal PET-CT, and low rectal cancer, thankfully in this case, was FDG avid. There was a left pelvic sidewall lymph node in the middle image, and there was a single liver metastasis which was reported. So the key questions that are needed to be answered before we manage this patient is the TME plane safe, total mesorectal excision plane safe. Are there high risk factors for local recurrence or poor outcome, which include extramural spread more than 5 millimeters, involved mesorectal fascia, that is CRM, extramural vascular invasion, tumor deposit, and pelvic sidewall disease? And do we need to consent the patient for a permanent stoma? So these are the questions that needs to be answered, and MRI can answer all these questions. I won't go into the details of MRI do's and don'ts, but I want to say that MRI should at least be performed with a 1.5 Tesla, and all our energy must be directed to high resolution T2 non-fat suppressed MRI, which should be a small field of view with the in-plane resolution of 0.6 into 0.6. The way to calculate in-plane resolution is with the ratio of field of view by matrix. So keep this as a benchmark, and it's very important to invest time and energy into this sequence because all the money is there. In our center, we don't use contrast, we don't prep the bowel, we don't give spasmolytics. So as I scroll this, you can realize the sagittal image includes L5S1 level and the whole gluteal fat pad. That should be the inclusion in your sagittal plane, and the axial plane should go 5 centimeters above the top of the tumor. Here we can see a low rectal cancer. Let me scroll this image and you will see that there is a left pelvic side wall lymph node, multiple tumor deposits which are irregular. There's mesorectal facial involvement and it's an intermediate signal tumor, and this tumor was involving the anorectal junction and showed diffusion restriction. Then we look at the diffusion weighted images of the upper abdomen, which is a part of our routine in all rectal cancer protocols. And what you see here is 4 liver metastases. And this is a very common scenario where diffusion weighted images are much more sensitive than PET-CT in picking up colorectal liver metastasis and must be a part of all our protocols. But the best sensitivity can be achieved with a combination of diffusion weighted images with contrast enhanced MRI. So we stage this as a T3D N1C M1A low rectal cancer with left pelvic side wall disease with multiple high risk factors. So patient underwent high risk protocol, which is total neoadjuvant treatment with a curative intent. What is TNT? TNT is we give all the chemotherapy in the beginning of the treatment, followed by long course chemoradiotherapy, followed by surgery. That is TNT. So this was the reassessment or restaging MRI-1 after 4 cycles of CAPOX, and you see incomplete response, which is seen as a nodular diffusion restriction, intermediate residual signal, and the CRM was still involved posteriorly. Left pelvic side wall was, however, resolved. Among all the metastases, only one remained, which was faintly seen in the liver. And the decision in the MDT was to go ahead with long course chemoradiotherapy and to do another HRCT to exclude lung metastasis. I just want to request another 1 minute, please. Yeah. And so after the MDT2, patient was restaged with another MRI and a HRCT showed just inflammatory changes. And the second restaging MRI 8 weeks after completion of long course chemoradiotherapy had a persistent liver lesion, T2 hypointense post-treatment change in the posterior wall, still involving the anorectal junction. And as I scroll this, you will see that there is all the EMVI which we saw previously has become thick T2 hypointense cords involving the mesorectal fascia. And there is no diffusion restriction on the DWI images. Any mesorectal lymph node that is less than 5 mm on the post-treatment scan can be dismissed because they are not significant. And so this patient was staged finally as complete response with a MR tumor regression grade 1. And the MDT decision now was to do a standard abdominoperineal excision, liver metastatectomy because there was only single one, so wedge metastatectomy was done, and the pathological stage in this patient was a YPT0N0, and even the metastasis was only post-treatment change. So the take-home is T2HR is the most vital sequence. Time and energy must go into that. Always introduce a liver diffusion weighted images because as you saw, you can pick up more metastasis in diffusion weighted images. Incorrect stage is inappropriate treatment, and in rectal cancer, it's a tightrope walk, and so we must take care of good quality images. Do not use the word CRM. I purposefully avoided that in my presentation. It must be replaced with distance to mesorectal fascia. And when it's less than 1 millimeter, it is an involved mesorectal fascia. This is just an image from the Occam trial showing you that this particular finding has the highest inter-observer and intra-observer correlation and accuracy compared to all other things that we say. And always go for MRI and not CT because CT will overstage. And though we may have multiple reasons to prefer CT, it is always MRI for local staging of rectal cancer. So with that, I just want to leave you with this resource, which is in the latest JGAR journal, where there is a special issue on rectal cancer imaging, where there are experts from across the country who contributed to this issue, all the way from Kashmir to Regional Cancer Center Trivandrum, and it's a good resource to refer and learn about rectal cancer MRI, which gives you these kind of questions that I just spoke about, and it takes you through the steps of reporting like this. And some of this we've presented in AOCR and in SCAR previously. And this is the last for you. And this gives you the structured reporting template for rectal cancer staging and restaging. Thank you very much. Yeah. And sorry for overshooting the time. Yeah.
Thank you, ma'am, for taking us meticulously through the nuances of colorectal cancers with such clarity. We will now proceed for discussion and queries.
Nice presentation, Dr. Gaurav, Dr. Madhusudan, and Dr. Anuradha. There's one question from the audience for Dr. Gaurav. How to differentiate gastrohepatic ligament spread? Well, that's a continuous spread from the gastric cancer from the perigastric nodes abutting the wall. How to differentiate between a contiguous spread from the gastric cancer along the gastric hepatic ligament from nodes in the perigastric nodes in the lesser omentum.
Yeah, so the question is how to differentiate spread along the perigastric ligament from lymph node. So as the name suggests, lymph nodes would be well-defined, circular or elongated ones. And if they are along the perigastric, they are known as perigastric lymph nodes. But a spread would be either contiguous, direct spread, or it would be thickening of the ligament. So morphologically, they would seem different.
True, and when we do a diagnostic laparoscopy, this bit is even better obvious, the nodal spread and the contiguous spread. And like what you rightly mentioned, the peritoneal disease is much better seen through a diagnostic laparoscopy, and we routinely do a peritoneal lavage and look for any cells in it. And even if it is not morphologically visible, and if there are any positive cells in the washout, it is still considered as a peritoneal disease.
Next question is to Dr. Anuradha. How to look for extramural spread in CA colon?
The way to look for extramural spread is to extrapolate the normal appearing colonic wall onto the tumor, and everything that is outside is extramural spread. So you extend the normal margin into the tumor, and whatever is outside that line is extramural spread.
Another question over here is carcinoid component in appendix or distal ileum. Where is it more common?
So appendix also has a high incidence of carcinoid. So the incidence wise, I think they are more or less similar, but I don't think that will help in changing your diagnosis. If there is any enhancing tumor in the appendix, I think so it's more likely to be a neuroendocrine tumor of the appendix. If that answers the question.
Thank you. It was a wonderful presentation covering from stomach to rectum. Excellent with the picture demonstration. It was very nice presentation. Thank you.
So thank you everyone. So at the end, I would like to say these GI malignancies are especially on rise in young population nowadays with lifestyle change and dietary modification. So as radiologists, we need to pick them up very early, and especially young females coming to us with Krukenberg tumors. So do look for GI primaries, and sometimes in occult cases, PET CT plays a role. So as a radiologist, we must judiciously choose the modality which we will be using, and all our three speakers beautifully illustrated the cases and the use of judicious use of modalities. Thank you very much.
That brings us to the end of the discussion. We thank our chairpersons, Dr. Neha Bagri, Dr. Karthikey Selvi, and Dr. Satish